for taking time off your very busy schedule on the front lines, taking care of patients. But I'm really glad that we could have this chat today. And what I'm hoping that we can do is to just have a conversation that can inform people about this major problem that we see that is increasing in African countries. You know, what is it and what is it that we should do? We should be doing to protect ourselves, to make sure we get diagnosis on time and to get treatment. You know, what is it that we have to do as, you know, as people in our communities and families?
Yeah, definitely. Thank you so much for inviting me. Yeah, I mean, cancer is a major, major problem. So anything to assist.
Yes.
Yeah, I'm
Yes.
happy to be here.
Yes. No, I think, you know, I have been looking at the numbers, and I mean, it's looking at the statistics, they are very alarming. And it seems that in Africa in particular, cancer is really on the increase. The WHO estimates that 90% of cervical cancer deaths each year globally are occurring in low and middle income countries, such as those on our continent. And our region in Africa is accounting for a third of all deaths that happen from cervical cancer. And these are cancers that rarely cause that rarely kill women in North America, in Europe. And when we look at the survival of women who get cancer in Africa is very poor. I saw some pretty scary statistics that 1 in 10 women who is diagnosed with cancer in sub-Saharan Africa will die within 6 months of diagnosis with breast cancer, for instance. And within 3 years following that diagnosis, 50% of those women would have died. Can you just talk to us a little bit about why survival from cancer is so poor in our countries, in our communities?
Yeah, so yes, it is a major problem. And you rightfully touched on cervical cancer because for us, cervical cancer is the most common cancer in Zimbabwe. About a third of our women actually diagnosed with cervical cancer every year, and we lose quite a significant number of those patients. And like you said, definitely in sub-Saharan Africa, it is the number one cancer for a lot of the other countries within this region. So, what we find with cervical cancer is we are still far, far behind. It is a cancer that, we can screen for. It is accessible. We now have tests such as the pap smear, which has been in existence for decades. And nowadays, we also have the VIAC, which is visual inspection with acetic acid, where you apply vinegar onto the cervix and you check to see if there are any changes that point towards cervical cancer development. So these tests, if done appropriately and on time, they pick up cancer early. And pap smear is even better because we pick up the cancer in what we call precancerous stages. So with cancer, we have a window of opportunity during which the cancer actually grows before it becomes invasive cancer. So usually it averages 10 years. So during those 10 years, a woman doesn't feel anything. You don't have the usual symptoms of vaginal bleeding, discharge, or pain during those 10 years. So it's a long time for us to be able to actually pick up that there's a problem. But unfortunately, in the African countries, we actually don't take advantage of the pap smear tests, which can pick up, like I mentioned, the cancer before it becomes invasive. And it's actually treated so that the woman doesn't actually develop cervical cancer and it's not recorded within the statistics. So that will explain in the developed countries why their figures drastically went down, and it's something that they're not really concerned about. So you find we actually struggle when we go to international forums, the conferences, and we raise our hands and say, we've got this major problem. I had this patient with cervical cancer, stage 3, stage 4. What should I do for her? And you're trying to share with other oncologists, but in the Western countries, they all like, really? Okay, we don't have experience in treating cervical cancer, especially that advanced. So you end up seeing that it's mainly still an African problem, and it should be something that we definitely need to do something about. Because as most people know, when cancer is diagnosed at an advanced stage, it means that it has moved from the part or the organ that it has started from and spread either through the lymph glands to other parts of the body, through the blood. It can go to the lungs, to the liver. And once it's done that, we are not able to cure it.
Yes.
And it really pains me, especially for cervical cancer, because we're finding women in their 20s, 30s, 40s. These are women that are active in society. They've got young children. They need to live long, full lives. But unfortunately, cervical cancer is cutting their lives short. So there is still, something that we really need to look at as Africans and see how best can we follow the general population accessing pap smears, VIAC tests, and screening early and preventing this disease.
Yes, yes. So I mean, look, the tests are there, and from what you explained, they don't seem like they are incredibly complicated or very expensive to just be screened to have a pap smear. But it seems that it's taking an incredibly long time for us to get to those women. I mean, it's a long time window, 10 years within which you could potentially detect that cancer and put that woman on treatment, and affecting primarily young women with children. I mean, that's a huge loss to our communities, that we are losing women in the prime of their lives. So what are the barriers? What is stopping women from being able to get the screening? I see that you've been doing a lot of advocacy work trying to encourage women to get screened, to get tested on time. But obviously a lot of women in our communities are not able to get that service, to get the screening services, to be able to be detected if they have a cancer within that enormous time window of 10 years. What are the barriers? Why are we not able to get to these women?
Yeah, so there are quite a number of factors that affect, screening and access to screening. So yes, you're right. I mean, I've been trying to, to get the word out, to have women know that there's this disease and it's a major problem. And just by the virtue of being a woman, one is definitely at risk. I mean, the other factors that increase a woman's risk, this is a disease of women that have been sexually active, because what causes it is the human papilloma virus, the HPV virus. So one acquires that sexually, yes. So we do advocate from the age of 21, all sexually active women should have pap smear tests done or VIAC tests done. Or if one has sexual activity at an earlier age, so you count from 3 years after your first sexual activity, your sexual debut. 3 years later, you have to start having the tests done. So you have them done annually. So, what I found was going on TV, on radio, talking about cervical cancer, screening, the tests. A lot of women actually, did want to have the tests done. And I had a lot of queries that came in. Where do I have these tests done? So that's the problem that came up, is where do women have these tests done?
Yes.
So we do have places where women can go, but then the issue came was cost. The pap smear is costly. You're looking at the stuff that needs to be used, the speculums that are used, spatulas that are used, and special slides that are taken to the labs. And then there's a lab technician who's specially trained to read these slides. So that costs on average $20 to $50. And a lot of women are not able to afford that. So most women were asking, where can we actually have these done for free? So within the government institutions, the council clinics, the VIAC test is done, but also some of the places had waiting lists and then don't have the capacity to actually test all women. So cost issues are an issue. and also availability. We haven't decentralized a lot of our tests, our investigations, and treatments. So women have to travel long distances to actually come and access screening and treatments. So that's also a problem, that somebody in Binga, for instance, they're like, okay, I want to be tested, but I have to travel hundreds of kilometers. So cost of transport also becomes an issue.
Yes.
And the other thing that we face is, once we've diagnosed the cancer, some of the women now need treatment.
Yes.
And you start talking surgery, you're looking at thousands of dollars on the private sector, the government sector, they have waiting lists. So that's a problem. This woman says, you have asked me to go for testing. I've got cancer, do something about it.
Yes.
And you're charging her thousands of dollars.
Yes.
So that also becomes an issue for us to say, once you're advocating for a screening test, patients should have access to treatment. And we need to boost our treatment services before we go on that worldwide or countrywide campaign. So those are some of the issues that sort of hold us back when we know that there's a bottleneck in terms of accessing treatments. And then the other thing that we face is just general fear amongst women. So, and they fear just being diagnosed with cancer, to say, I'd rather not know, because knowing that I've got cancer, they think it's a death sentence. So it's more a psychological barrier to say, I just don't even want to know. I'll bury my head in the sand. So we try and, work with women to let them know that if we do find a problem, if you're having screened and you're not yet symptomatic, a lot of the chances we find it early and you can get treated and go on with your life. So a lot of education still needs to be done around that. So, and a lot of the times also it's the invasiveness when you're talking cervical cancer. I have found a major challenge with the fact that the HPV is sexually transmitted. So a lot of women don't actually understand what that means.
Yes.
Because the moment they're diagnosed with cervical cancer, then for some women, they can start blaming their sexual partners and say, you are the one who's given me this disease, which for some women, it leads to divorce and unhappy marriages.
So a lot of
And
social stigma attached to the diagnosis
yes,
itself.
that comes on. It's a problem, yes. And also, the past few months, I've actually been challenged by a colleague who's in the United Kingdom, who says, you're a cancer specialist and all we hear is breast cancer, breast cancer. What happened to cervical cancer? Is it not the number one cancer in Zimbabwe? And I said, yes, it is. But they said, how come nobody talks about it? We all know about the October month. When is the cervical cancer month? And for sure, it's not something that's, well talked about. And, yeah. So what we found was a lot of women with cervical cancer actually, think, okay, there must be something wrong with my disease, because, people are not out there talking about it. No, pink this, pink that. Yeah, there's not much money that goes into the, the events that are associated with cervical cancer.
Yes.
When you compare to breast cancer, where people do pink golf days, pink breakfast, it's also fancy. But cervical cancer is our disease as Africans. How come, we're not out there spreading the news and doing a lot of advocacy work? So what I ended up having to do was to initiate a patient support group to actually help the women to group together, to support each other and know that they're not alone. Because that's the thing that I found, that a lot of women, once they're diagnosed, they just think that, okay, every other woman has breast cancer. Very few women have cervical cancer, so they're isolated.
Yes.
But this support group is actually help them realize that there's more of them.
Yes.
And with that, we're kind of hoping that they will initiate the programs that will help us put cervical cancer in the limelight.
Yes. No, that sounds like a great idea, to have patient groups that as part of the awareness raising. And that seems to be a major problem, apart, of course, in addition to the fact that the systems that are needed to be able to reach those women with screening and diagnosis do not always work. You mentioned that the system is not decentralized, which means that women have to travel. If they are in a rural setting, they have to take the bus to the nearest town, urban center where there is a hospital or a clinic that has the capacity to actually do that screening. And then, of course, it costs money, long distance is involved, and so forth. But I think, this part about information for me is also very important. The fact that women are not aware, they don't know what it is, so there is the fear, the stigma. And I noticed that you have been working with Chicken Heart and partnering to as part of your advocacy work to increase awareness. So talk to us about some of the things that we could do in communities to bring that information to women so that they are aware this is a common problem, so that we talk about it more. What is it that we can do within our communities? Are there things that businesses can do to increase awareness within the workforce? Are there things that I don't know, within churches, for instance, religious communities, are there things that church elders and people, elders within the communities could do? What could we be doing more to educate or to provide women with information that this is an illness that if we can pick it up early, you could actually get treated and recover, and you don't have to be afraid of it?
Oh, yes, definitely. There is a lot that we can actually do. And from my end, I think working with the cancer survivors helps. Because, since a lot of people actually think that, having a cancer diagnosis automatically means death. If they see somebody who's had cervical cancer treated 20 years ago, 10 years ago, 1 year ago, they actually more likely to believe that person, to say, okay, they suffered from this disease, but look at them, they are healthy, they are alive, they are thriving. They had the surgery done, what we call a total abdominal hysterectomy, that's removing the uterus. But the surgery didn't kill them. There's a lot of stigma around surgery. They didn't lose their husband because they had no uterus. They're still a woman. They had radiotherapy done. A lot of people fear radiation. They think that they're going to be burnt. So seeing somebody who's actually had radiation talking to them will actually help them believe that, they can also go through that. Chemotherapy, the same, a lot of myths around that. So that will actually help. So with these cancer survivors, we can identify champions from different parts of the country, because we've had patients from all over the country, really. So just to identify somebody from Bulawayo, from Manicaland, the different provinces, to say, yes, you are representing this province. Can you help to work with the rural clinics there to talk to women, maybe organize weekly or monthly meetings in that rural center, and give the talks, respond to questions, and so that people actually identify with somebody that's been through the journey. And that woman will also serve to support any other women that would be diagnosed and walk them through the journeys that they would be embarking on. I think we can start by working with this patient support group that we've initiated, and empowering them to go out there and work within their own communities.
That's a great idea. Having champions that women can relate to and see that, well, they have gone through it, they have survived it, and they surely I could survive it too if I have had a diagnosis. But so that's great. So that's one, maybe a community intervention, something that communities can do to raise awareness. But how can those groups be supported better to be able to actually do that work? I mean, are we doing enough to bring that information to increase awareness within our communities? But I'm thinking at a national level, ministries of health, are they doing enough? What is it that could be done more? I was reading somewhere that two-thirds of countries in Africa have a national cancer control plan. In some places, it simply isn't there. So there is no prevention services, preventive services that are available, which means there is no communication around what cancer is, how to get screened, and so forth. So what more could be done, do you think, at least in your practice as a practitioner, what you're experiencing on the ground? How could governments in general support by having the right policies and so forth? What is missing?
Yeah, so in Zimbabwe, we're proud to say we have a national cancer strategy that we've developed, and the cancer control plan stems from that. So basically, it looks at all the facets of cancer, from all the way from prevention, early diagnosis, screening, treatment, and palliative care. So we are actually, doing quite a lot. Looking at prevention, we have, the HPV vaccine that we have, started in Zimbabwe. So I'm proud to say that, yeah, quite a number of girls have had access to that, young girls between the ages of 11 and 13 years of age. So the vaccine, we're saying we want to catch girls early before they become sexually active, and they're vaccinated against this human papilloma virus, such that by the time they become sexually active, they already have protection. And we're hoping in a few decades from now, we'll start seeing the decline in cervical cancer cases from this intervention. And then, yeah, the screening services, yes, there's the VIAC tests that have been done, but with the VIAC tests, they are not as accurate as the pap smears, but the advantage is they're cheaper. So a lot of provinces have access to these VIAC tests, but because of their lack of accuracy, especially in women over the age of 50 years, we still find some women that we miss disease. And unfortunately, that woman is, once she's had a VIAC test, which says she's negative, she sort of relaxes even if she's having symptoms. And by the time we see her as cancer specialists, some of the women, the cancer is advanced. So that's something we really need to look at and have more pap smear tests available. Yeah. So within that cancer control program, we do have the treatment services. We've been working with a number of partners, the WHO, the United Nations through the International Atomic Energy Agency arm, which has helped support our radiotherapy services over the years. So right now we're actually working on a country program framework that helps us work with the International Energy Agency. And we try and put a lot of things into that country program framework, all the prevention services that we want to do. They support us, the treatment. They also support with human resource development, training of specialists, of the technicians, radiographers, the physics support, and a lot of technical support with machinery. They've helped us acquire some of the radiotherapy machines, and supporting them in terms of maintenance, engineers to maintain these machines. So we have had quite a bit of support through the Ministry of Health and the partners. But definitely it's not enough because, like I mentioned, still just centralized to Harare and Bulawayo. We need more machines to access people that are in more remote areas.
Yes.
And
So
then,
so you yes. So you have to be in Harare or Bulawayo, which is the capital and the second capital, to be able to access some of the treatment services that might be available. And that pretty much leaves the rest of the country pretty much. If you don't have money to travel to those places, then you're on your own by the sounds of it. So I think it sounds like we really need to think about how we can reach more women outside of the cities to with those services so that they can get screened on time, get the treatment. So let's say we've managed to deal with the information. We have managed to give a woman the information that she needs about the screening. She goes for screening and hopefully she gets a diagnosis on time. Can she get the treatment? I mean, that's one of the major challenges, I understand. How accessible is treatment once women get to that point that we know they require either radiation treatment or chemotherapy, depending on the stage of their cancer?
For the treatment services, we're looking at surgery. So surgery, we do that for early stage disease, usually your stage one cervical cancer. So surgery is readily available because we've got a lot of gynecologists. They are the ones that operate on the women, and that's pretty much decentralized. We've got gynecologists in almost all the provinces in Zimbabwe. So there's a benefit there, right there, for catching cancer early within, the stage one disease. So a patient can have their uterus removed and they're cured. But for the more advanced stages, stage 2 and 4, surgery is not enough. And for some women, they cannot even have surgery done. So they require radiotherapy and chemotherapy. So radiotherapy, currently we have 3 working machines in Zimbabwe. And for a population of 14 million, that's definitely inadequate. We need a minimum of 10 machines for Zimbabwe, and that's a minimum. So we have a long way to go. And these machines are very sensitive machines. They break down frequently. We don't have resident engineers. We have to wait for technicians, engineers to come in from out of the country. And we found, especially during the COVID travel restrictions in 2020,
Yes.
yeah, there's a time when we didn't have radiotherapy services at all for a few months
Wow.
because the technicians could not come into the country as, there were no flights. So we really struggled last year. Really, really.
Why do we need technicians to come out of from outside the country? Can we not train our own technicians and have people in the country who could service this equipment? What do you think is the problem there?
Yeah, so with the technicians, a lot of it, has to do with brain drain. We can train technicians, but unfortunately, once they're trained, we don't train them locally. They train out of the country. Some
Yes.
of them end up, staying in the country that's trained them, and they don't come back. And
And that's
mainly,
a problem that is not just restricted to technicians. I suppose it's a problem that is affecting our communities from having enough physicians in the first place, enough oncologists. Do we have enough oncologists in Zimbabwe to meet the demand, the to be able to meet the needs of patients? Are we training enough? I mean, you are teaching in the University of Zimbabwe. Can you just tell us a little bit more about what we are doing to make sure that we have enough doctors to take care of patients in our communities?
yeah, so the training, I think we've done a great job. We do have a training program with the University of Zimbabwe, the College of Health Sciences. So there is a radiotherapy department that trains oncologists. So we are clinical oncologists trained to administer both radiation and chemotherapy, which actually comes in handy, yeah, for a country like Zimbabwe.
Mhm.
So now we can say we have about 13 trained oncologists, which is quite good because for a long time I think we only had 2 or 3, but
So
over the
13
past
is good for 14 million people, you think?
Oh, definitely not. It's a drop in the ocean.
Yes.
But from where we're coming from, it's
Yes.
a big improvement. Yeah. And we have, I think, about 10 in training that will qualify in the next couple of years. So hopefully we will be about 20 soon. But
If you
having
can
said
keep them, right? 20 if you can keep them, because
yes,
a big proportion of them will probably leave and go and look for greener pastures.
yes, that is so true. And the main reason for that is remuneration.
Mm.
You find that, people that have been trained are expecting a particular, income. after having gone through 5 years of specialist training on top of their initial 5 to 7 years of undergraduate training. So when we're not able to remunerate them accordingly, then it becomes an issue. And another issue is just that access to the radiotherapy centers. So once you start having 20 oncologists all congregating around one machine, one center, then that becomes a problem. So as the government, I think there is really a need to decentralize so that oncologists that we're training are able to go to other centers and and work from there, not have us all in one place. So with remuneration, like you mentioned, that it's affecting across the board, so the technicians that we mentioned, physicists. But having said that, also we're training through NUST and the University of Zimbabwe. Medical physics is something that we're proud to say we've started training. Radiotherapy technicians or radiographers, those also we've been training for quite some time now. Although yes, we've lost quite a number to the region and to our other countries, but we have retained quite a number. So what we mainly need is actually more centers in other cities, other towns in Zimbabwe. Yeah.
Yeah, so you need investment in building more cancer clinics around the country where those physicians and physicists that you've trained can technicians can be able to go and provide services to people. What about then, because this idea of health workforce challenge is not having enough. I mean, 14 going up to 20, depending on how well you're able to retain that, it's still not enough for a country, a population that big. And I've heard a lot of talk about how the nurse-led care. In some countries, that's one approach that people are taking with the support of physicians who are not many, but perhaps if those physicians can be connected to the nurses who can do perhaps follow-up care for women, especially in their provinces, in their districts, that could bring services closer to the people, reduce the cost of travel and perhaps the cost of getting the treatment as well. Is that something that you think could work? And is that something that even would be accepted as a solution to the challenge of not having enough people, not having enough infrastructure, clinics, real clinics closer to where the people need these services?
Ah, yeah, that's an excellent idea and suggestion. We do have well-trained nurses in Zimbabwe. That's something that we're proud of. And we have introduced a oncology nursing training program through the Paringatwa Hospital Nursing School. So we're training oncology nurses. Annually, we're releasing quite a number of these nurses. And it is something that we can definitely look into to just make sure that every province is covered by at least one oncology nurse who can be the central person in terms of providing care for oncology patients. So that way we're decentralizing our care. So a lot of our patients, because they come with advanced stages, about 80% of our patients come with stages 3 and 4 disease, they require palliative care. So it is a pity to see patients traveling all the way to Harare for palliative care. So palliative care, mainly we're administering morphine treatment. So with that, there is talk regarding allowing patients, nurses, training the nurses to prescribe morphine. In Zimbabwe, morphine, we call it a dangerous drug. So it's only doctors that prescribe it. But we are looking into, allowing the nurses to prescribe it. And therefore, we're decentralizing that palliative care. But definitely in terms of follow-up of patients after treatments and getting the needed support, they can be communicating. And now with telemedicine, they're able to actually communicate with the doctors, the specialists, the nurses, once they see the patients. And, we give care that way. So it is definitely something that, we will look into.
No,
Mm.
that's really good. It's something that I thought about. I was talking to somebody. I don't know if you know Kids Can. They are dealing with childhood cancer, and he was explaining to me how after COVID, a lot of these kids were not able to come to Harare, to the capital city, to the central hospital to be able to get the follow-up care that they needed. And he was explaining that in some cases they were thinking about getting a bus to go and get those children to be able to bring them. And I'm thinking, perhaps we could just think of a way that we could come to them, because these are kids, or these are patients who are very, very sick, and it just seems quite cumbersome to ask them to make a 2, 3, 4 hour journey just to be able to come and get the follow-up care that they need. And I wondered what could be the reason for this. So you mentioned already that it's the policy, the way the health system is structured, it's quite centralized. But we do have district hospitals, right, that are a lot closer to communities than the central hospital where they have to come to. Are they are patients having to come to the central hospital because the district hospitals or provincial hospitals aren't equipped or able to handle that follow-up care in terms of having the right staff, the right skills, the right equipment? Why is it that people have to come to the central hospital?
Yeah, so a lot of it is the lack of being well equipped. So that's just human resources, looking at the nurses, the doctors that are able to deal with specialized care. So what we're actually trying to work on are national cancer guidelines.
Mhm.
So cancer treatment and follow-up guidelines. So we have, the more specific, the more specialized guidelines that we generally follow, for our radiotherapy, chemotherapy services. But as a nation, we coming up with more basic guidelines that
Yes.
will help to guide the nurse in that rural health center in the district hospital, will guide that young doctor out there to say, if I'm faced with a patient like this, who's got a lump, this is what I do. If I'm faced with a patient that's had cervical cancer treatment, how do I follow her up? What sort of tests do I do? So we are working on that. And within that sort of guideline, we're working on the resources that we need to actually equip these rural health centers, the district hospitals. And we're hoping once we've completed this exercise, we will actually have an improved health service delivery in terms of cancer management and that decentralization. So definitely that is something that we're working on. But in terms of resources, yes, we do find, because we're going through financial problems within Zimbabwe, a lot of the centers, have run out of the necessary medication. They do not have even basic medication. So a lot of patients end up going to the mission hospitals,
Yes.
like Karanda Mission Hospital, for instance. It's inundated with patients.
Mm.
And, because they know when they get there, they're likely to get some sort of painkillers that they get, operations, they do quite a number of surgeries that they do. The mission hospitals are helping to fill in the gap, but it's still not adequate. So
Yes.
we do need to improve on our own Ministry of Health centers, and have patients access, because for current hospitals still patients have to travel hundreds of kilometers
Get
in
there.
certain instances. Yeah. And the challenge with the travel that I found is with cancer management, especially if it's radiotherapy treatment.
Mm.
This is treatment that lasts 5 to 6 weeks as
Yes.
daily treatment, Monday to Friday. So a patient that's come from 400 kilometers away, they have to have a relative in Harare where they're going, because it's outpatient treatment for the 6 weeks. If they do not have relatives, where do they stay?
Yes.
So we've struggled with some of the patients that have had nowhere to stay, and if they have to stay in hospital, that sort of increases their hospital bill.
Yes.
So that's an issue. And even the ones that have relatives, during the COVID pandemic that we're actually experiencing right now, a lot of people don't want, even their own relatives that have traveled to come into the home because that exposes them to the virus. So that's also been an issue to say a patient comes in, even coming in for review. Some would have traveled, they get onto the bus at midnight. I see them at 8 a.m. and they immediately want to go back. And I say, why don't you stay a few days for your tests? And he said, there's nobody that wants to actually, house me because they're worried that I've picked up corona on the bus. And, so it's a serious issue. We have a few organizations that have been offering accommodation to patients, such as the Cancer Association of Zimbabwe, that has a hostel, Mpilo Hospital for the oncology patients getting radiotherapy, and Harare Hospital. They have a hostel there that houses patients, but still, that is not enough. So
Yes.
the decentralization will definitely help. And then
Yes.
looking at chemotherapy treatment, also, this is treatment that's given every 3 weeks for a lot of patients, and we do it over 6 months. So they have to be coming in and out, back and forth, back and forth. And chemotherapy is so sensitive once you've administered it to a patient, the immune system goes down. So anything can happen during the 3 weeks break when they're supposed to recover. A lot of the patients, they fall ill, they get fevers, and they need to quickly come back to hospital for us to, to give them supportive treatment, antibiotics, IV hydration. But if they're far away, how do we support them after we've administered this treatment?
Yeah.
So it becomes risky for the patients that are far, far away when they can't easily get support that they need during chemotherapy. So
Absolutely.
it is the distance issue is something that, yeah, should be definitely on top of our priority list. Yeah.
Sure, yeah, yeah. And it seems that obviously you mentioned at the beginning of our conversation how when you go to international meetings, you are presenting these problems that others are no longer experiencing. How to look after patients, a large number of patients with advanced cancer, advanced breast cancer, advanced cervical cancer, which your colleagues, your peers in more wealthy countries no longer experience. So, at the university, are you, or in the region even, is there research happening around improving the standards of care? Because obviously, this is a challenge that is very unique to our communities, to our situation, to our context. Patients not being able to have accommodation, to have transportation, to be able to reach a health facility where they need to be hospitalized, they need to come back for an extended period of time. How do we improve the standards of care for those patients? Are we doing research at least to look into this to see what models would be cost effective, would allow us to provide that care in the most efficient way possible, and of course most practical for the patient as well, and at the end coming out with better cancer survival rates for these patients, because that's the problem, isn't it, that the survival is just so poor. We are losing way too many people.
Quite a number of initiatives that are being done in Africa to try and address the issues. And I'm proud to say I'm part of what we call the African Cancer Coalition, which is a group of sub-Saharan African countries that have come together through the assistance of the American Cancer Society and the NCCN, which is the National Comprehensive Cancer Guideline, American Guidelines, Cancer Guidelines. So this African Cancer Coalition, the main mandate was generally to come up with cancer treatment guidelines for Africa. So we adopted and adapted the American NCCN guidelines to the African setting. So we had a series of meetings as sub-Saharan African countries where we shared our own experiences, and like you just rightfully said, we all having similar problems, the advanced cancer cases, lack of resources. So that actually helped us to say, okay, how then we've adopted and adapted these American guidelines. And a lot of the times we're looking at actually downgrading from best standard of care to say, okay, we don't have this particular type of test. What's the next best thing? So we felt a lot of the things that we're downgrading to are more inferior. So the next question is, how do we then get our standards to that American standard and not just say, we don't have this, we don't have this drug, we don't have immunotherapy, which is, quite standard now in a lot of countries. What do we do? So we're still holding meetings. And with that, one of the main thing is to say, how do we improve access to services? How do we improve the radiotherapy, chemotherapy services? So in terms of chemotherapy, the African Cancer Coalition has worked with CHI, which is the Clinton Health Access Initiative, to come up with an access program to drugs. So what CHI has basically done is negotiated with a number of reputable pharmaceutical companies that offer generic and actually brand drugs as well, to negotiate, after pulling the African countries together, we are able to actually negotiate cheaper prices. And so we basically become one market, and through that have donated prices. So that is helping us access drugs at a cheaper price. So the government of Zimbabwe is working on that to import drugs for our patients through that initiative.
Yes.
So that's a positive from this African Cancer Coalition. So research is also another factor that we're looking at. Only yesterday I was talking to a professor in South Africa who's setting up a program that he's saying he wants to establish immunotherapy research. And his thinking is a lot of the drugs that we utilize in Africa have been developed in other countries, in the Western countries. And we take on these drugs and we use them on our patients. But is this exactly the same? Are the reactions going to be the same? Are there no unique things that we need to look at in the makeup of the African population that has to do with the environmental factors, genetic makeup that we need to look at? So this research will help to sort of customize our treatments to our environment and improve, outcome of our patients, improve tolerance to the medication. So I was quite excited to hear about that. So we will be working with them, with the African Cancer Coalition, to improve research. So yeah, there is a lot that we're doing, but definitely we need to partner with more organizations, African organizations, international organizations. We need more access to funds, because a lot of these things are very well, we can sit and say, yes, we can do this, do that, but without the funds, we can only go so far. Yeah. So, yeah.
Yes. But it sounds like, of course, a lot of this boils down to collaboration, because these are big problems that no one institution is going to be able to solve on their own. But I think the point that you make about the data or that you have, what you're using to support treatment programs or to develop treatment guidelines in countries, is data that is really coming from elsewhere, from situations that are very completely different, with completely different resources. So what I'm hearing is that there is a huge need for us to generate our own data that supports the clinical guidelines that we are using in our own clinics, which are relevant to our own people. And this issue of where the treatments have been tested, whether it has been tested in a group of people that is similar to the people who are getting that treatment, it's a big problem in clinical trial diversity. So I think it's a great idea if we can, even as African universities, institutions, develop networks that are able to actually do these clinical trials and actually test how those treatments that have been tested largely maybe in Caucasian populations, how do they work in our specific, populations and their own specific vulnerabilities and situations and resources that we have. It sounds like a really great idea. So listen, Dr. Tsikai, I think, it's it's clear that we have big problems that we need others to work with us to be able to solve those things. So um, talk to me as a patient, right? I'm just a woman in the community. I live far away from a clinic. I don't feel very well, but I don't know what to do. I think, I don't know, it could be witchcraft, it could be anything. What should I do? What can I do to protect myself? What sort of things could I do to reduce my risk of getting cancer? And if I suspect that I might have it, what can I do? What steps can I take to get some care?
Yeah, so what's important is for one to know their body. So once you know your body, any changes that you experience, to take them seriously. Okay. So that is once you start having any symptoms for cervical cancer in particular, you're looking at vaginal discharge, bleeding, low abdominal pain, backache, to go to your nearest health center for treatment. It is unfortunate that a lot of women do this, but once they're there, they're treated as a sexually transmitted disease. They're given antibiotics. They go back after 2 weeks for review, and they say, "I'm still having the discharge." They're given another lot of antibiotics. They go back after 2 weeks. They're told, "Oh, bring your sexual contact, your partner, your husband. Maybe he needs to be treated as well." And then that starts causing issues on its own. So it is a big problem. So once women are empowered and they have the information, they're able to actually say, "No, can you please check me for this disease? I heard that if I have this discharge and it's not responding to antibiotics for 2 weeks, can you check me for cervical cancer?"
So it
you
comes
know
back to information again, because I have to know
they,
that it's not regular for me to continue to get antibiotic treatment and continue to bleed, and they just keep changing it. I have to have that information to be able to request that. So it seems, a lot of this really comes back to us women having the right information to be able to ask for the right kind of care. But why is it that the nurses at the health center continue to suspect a reproductive issue as a sexually transmitted disease and infection, instead of actually considering the possibility that it could be a cancer? Why does this happen?
So with that, that's where, the training comes in, and those cancer guidelines, the basic guidelines that we're working on are coming in. They're trying to address that issue actually, because it has been a major issue.
Yes.
So we actually say, now I talk to a lot of women and tell them, have, control over your own body.
Yes.
Yes, you can trust the nurses, you can trust the doctors, but at the end of the day, it's your body. Gone are the days where you go to a health practitioner and they just say, "Take this." You see them and they're quickly writing a prescription without explaining what you're suffering from. I always say, it's your right to pause them and say, "Explain, why are you giving me this drug? What are the possible side effects? What am I suffering from?" So the same, even with that rural woman, it's her right to actually question and understand better. But without that information, then it really becomes a problem. So we are working with that. But the guidelines hopefully will actually help the nurses in the rural centers actually address, and not just say, as long as somebody has a discharge, it's just, an infection. So we want to conscientize them. We're going to be holding workshops, regular workshops, just to keep, reinforcing it, to say also in this particular age group, have a high index of suspicion for this particular problem.
Yes.
Yeah.
So what you're saying to us women is that don't be afraid to question the care that you're receiving from your nurse, from your practitioner. If it's not solving your problem, speak up and ask for something else, or for them to test for other things if you feel it's
Yes.
not working for you.
Definitely, definitely. And there's an issue of second opinions. It's your right to seek a second opinion. You know, a lot of, especially in our environment, we have this thing, whether it's a cultural thing, that you are too embarrassed to seek a second opinion because it means that you're going to offend the first person that gave you an opinion. But it's your right, especially with cancer. I always tell my patients, you know, you have every right to go to another specialist and just seek a second opinion and go onto a website that offers second opinions. I've had a number of patients that have come with second opinions, and you know they've actually gone through my management plan and said, "Why did you ask for this? Why did you order this?" You know, so in certain populations, second opinions are not an issue, but in our culture, it's something that we actually have to say, "No, it's okay." You know, you've every right to go and ask, and you know, yeah.
Ask
So
someone
definitely.
else. Yeah, no, it's all
Hmm.
very well, I understand that, but just thinking how many women would actually be able to have that kind of information, to think, gosh, yeah, I need a second opinion. But yes, certainly, because not many people have access to internet and so forth. So how do we give this information to women? You've mentioned champions and other things, all the other advocacy things, but what is the system for providing women with this information? Where can they go to get this information?
Yeah, so definitely we can work with those rural health centers, give them pamphlets, put up posters. But what we're actually finding now is, almost everybody has a cell phone, if not a smartphone.
Yes.
So we have Econet, for instance, has been sending out health messages to people. So that is something that, we could actually do targeted
Yes.
messaging or population-based messaging that can
Yes.
go out regularly, maybe once a week with specific themes to say this month the theme is cervical cancer, and we just reinforcing the message. Have you had your screening test? Are you having any symptoms?
Yes.
Yes. And just going back to another question that you asked, how women can help themselves with prevention. We found that diet and exercise actually play a major role.
Yes.
So, yeah, so you find that these are things that we take lightly because, diet, the foods are readily available, the ones that we actually advocate for. These are our natural diets that, women in the rural setting have. But you find when women come to the towns, they find, they think fast foods are fancier, they are better, they are for more affluent, but not so. We're trying to rewire people, reprogram people to say, no, it's the foods that you left in the rural areas that are healthy. And the COVID-19 pandemic has actually helped people realize that because the immune system, once it's down, people are prone to more severe disease. So a lot of people have realized if we have our moringa herbs, zumbani leaves that people are taking, blackjack leaves, avocado seed, avocado leaves,
Yes.
they actually,
Yes.
finding that they're doing much better on that. So those sort of foods and diets actually help also to prevent cancer. The more
Yes.
natural greens have
Yes.
antioxidants that clear out toxins that cause cancer.
Absolutely.
Exercising 3 to 4 times a week, maintaining a good BMI, your body mass index, reducing obesity, actually also been found to prevent cancer.
Body
So these
mass
are things that
index,
don't
Dr.
cost us
Tsikai,
anything.
we don't know what that means. You mean our weight? You have to speak in a language we
I'm
can
trying to be
understand.
polite. When we're trying to be polite as doctors, we hide behind medical jargon.
Yes.
Yeah, so basically, yeah, body mass index. We factor in your weight and your height, and we calculate it to see if it's within a certain range. So usually, a figure above 25 means that one is overweight, and a figure above 30 means one is obese to very obese. So we want to remain within an acceptable range. I mean, granted that, people have different body structures, but if one, uses it, it can work as a guide to
Yes.
say, if I'm in this range, I am, in a healthy sort of weight. Because obesity, unfortunately, even though we have poverty in Africa, obesity is actually a big problem. And a lot of it stems from people eating those unhealthy fast foods, which, yeah, are just not healthy for us.
Yeah.
So, and also not exercising. A lot of people are leading sedentary lifestyles. So, obesity is an issue and it increases the risk of breast cancer, cervical cancer, colon cancer. So definitely, it's something that we need to make sure that we manage our body weight. Yeah.
Yes. Yes. So stay active, do
Mm.
walk instead of taking the bus or taking the car. Someone said to me, "Well, I think walking is for poor people." So, but the message is that you should engage or do some kind of activity and try to at least manage your weight by eating well, healthy foods that we find in our garden. It's interesting how in our communities these things that are like when you travel in the West, you see people paying a premium, paying a lot of money for basic foods that grow in our backyard, and a lot of people don't want those things because of the perception that that food is inferior when it's actually the best food. So it's great to hear you, Dr. Tsikai, tell us that those vegetables and those fruits that are growing in our backyards are actually the best things we should be eating to help us to stay healthy and to reduce our risk of getting cancer. What about things like smoking and those kinds of things? It's not a big problem, I suppose, for us.
Oh, it is. Smoking definitely is a big problem. I mean, you'd find a lot of places they're anti-smoking. You're not allowed to smoke in public places, on buses. But in Zimbabwe, we've lagged behind in terms of our smoking policies. And that has been because we're a tobacco grower. We rely on tobacco for the country's income. But it hasn't been good for the general public because passive smoking is an issue when you go into a restaurant or a pub and people are smoking inside. So definitely, and a lot of people, through media and what they see on TV, they think smoking is cool. So we're finding, a lot of youngsters are taking up smoking, which is a big issue. So we will find, lung cancer was never quite an issue before, but I think in the next few decades, if we don't actually control smoking issues in Africa, we will start seeing it become a bigger
Absolutely.
problem. Yeah.
Yes. Yes. No, it's true that in the West, they have really taken very aggressive policies to prevent smoking and to go after the tobacco companies, and in the way that they target young people, especially. But it's good to hear you say that there are things that we can do to stay healthy. Avoiding smoking, staying active, eating healthily. You mentioned vaccination earlier with the HPV vaccine. Is that something that is free that people can just how does a young person who think they would like to get such a vaccine access it? Is there a program? How does it work?
Yes, there is a program through the Ministry of Health. They did roll it out through the schools, so quite a number of girls actually got vaccinated. But now it's readily available in the pharmacies, so the parents can actually go and buy it, go to the general practitioner and get their daughter vaccinated.
Okay.
In other countries, they're also vaccinating the boys, but in Zimbabwe, we're still just doing the girls. But
Right.
yeah, definitely, it is now readily accessible.
Okay,
Yes.
so a parent has to decide that they want their daughter to be vaccinated, and they have to go and actually buy the vaccine and ask their practitioner to give it to the child. So that's quite a lot of things that assumes people would have to know and understand these things to be able to take those steps. So again, it seems to me that we really need to somehow bring this information to communities, to families, um, so that they are empowered to be able to take those decisions. Because it occurs to me that sitting in my house, it would never, I would never think that, well, oh gosh, I need to go and buy that vaccine and get my daughter vaccinated, unless somebody told me. You have to know that there is such a vaccine, right? So
Exactly.
that sounds like
Yeah.
a lot that we need to do in order to bring information, to equip people with the right kind of information for us to be able to protect women, to improve the survival rates of survival from cancer. I think, we are running out of time, and but is there any last message that you would like to leave us with, in terms of just how we should think about this, what we should do, how to stay healthy, and to get the right treatment that we need.
So just to remember, yes, it's important to take care of our bodies. So lifestyle issues are a major issue. To look at the foods that we're taking in. Are we exercising every day? It's important to avoid, the cigarette smoking, alcohol drinking as much as possible, and to listen to our bodies. If they're telling us something, if things are not okay, to go and actually seek help. And to remember screening. With screening, we're saying go for testing before you develop symptoms. Don't wait to see the discharge or feel pain, because by that time, a lot of the times it's advanced. So go for screening. Go to your healthcare practitioner and say, I need to be screened. I heard there's something called screening. What can I do? And please do that also regularly, especially if one has predisposing issues such as for the HIV positive women. They tend to have more aggressive cancer, and it grows faster. So they don't have that longer period where that we take advantage of the window period. And also just to remember that the cancer diagnosis is not a death sentence. There is a lot of women that have survived cancer. So it's important to realize that. And even if it will limit your life, but you can still live a relatively good quality of life with the treatments that we offer. So it's important, whether it's through the palliative care, the pain control that we administer. A lot of women, palliative chemotherapy or radiotherapy, a lot of women still survive relatively longer lives, even with advanced disease, through the interventions that we administer. So it is not a death sentence. There's always something that we can do for cancer. Thank you.
Yes, yes. But just one last question. So, what would you say to me if I say, well, okay, so I go through all this trouble to get all the tests, and in the end, I can't afford to get the treatment anyway. So why bother?
Yes, so that's where it comes in. The earlier we pick up the cancer, the easier and cheaper it is to treat. So I would actually advocate for early screening and early detection, because for women, where we catch it in the precancerous stages, we can actually just scrape the cells of the cervix, the part of the cervix that's affected, without actually going through an operation. Even with the VIAC tests, when they see early changes, they freeze those changes with liquid nitrogen, what we call cryotherapy, which actually is curative also. So when you're actually going out there every year, you're having your tests done, then your chances of picking it up early are much higher, and not having to go through the expensive treatments, the radiotherapy, the expensive surgeries, the chemotherapy. So please just be in charge of your body, and have screening done early before it's advanced. Because with the advanced cases, yes, the treatments are more expensive and more difficult to actually find, and they're not as accessible. Yeah.
Wonderful, wonderful. So, cancer is not a death sentence. So, don't be afraid to get tested, because the earlier it can be picked up, the easier it is to treat it. It's also cheaper. You don't need more complicated treatment. So, and above all, just be in charge of your body. Thank you so much for speaking to us today, Dr.
Thank you, Lynn.
Tsikai. I've learned a lot. I hope others will learn a lot as well from all of these gems that you have been sharing with us. And I hope that we continue to have these conversations, because I think there's a big need within our communities for people to understand what these things are, what they mean, and what to do about them once one is experiencing them. So thank you so much.